So hi everyone, good afternoon. Welcome to another ID-EPI seminar series brought to you by the Centre for Communicable Disease Dynamics at Harvard T.H. Chan School of Public Health. I'm your moderator again this week, James Hay, and I'm really excited to welcome Dr. Nick Grassley, who's a professor of infectious disease epidemiology, and he leads the vaccine epidemiology research group at Imperial College London. So there's a few logistics we need to cover before we get started. So this seminar is being recorded and it will be posted on YouTube later. So if you don't want to be on the recording, make sure that your camera stays off and you stay muted. We're going to maybe do something a bit different in the discussion at the end, where we might allow people to ask the question directly and have a bit more discussion with Dr. Grassley. So be aware that you might be part of the recording if you want to do that. So we've got normally we'll do 45 minutes for the talk. The Dr. Grassley the talk should take more like kind of 30-35 minutes. So it'll give us a lot more time for discussion. So we'll stop at about 20 to 2. So if you just send your questions throughout the talk, that we'll ask them at the end. So send those to Bene, who's one of the co-hosts. You'll find her in the participants panel. So now to introduce our speaker. So Dr. Grassley's usual research interests are in individual immune responses to vaccination and their impact on population dynamics of disease. And he and his group are some of the world's leading experts on poliovirus and rotavirus vaccination. So their work aims to bring rigorous statistical methodology to a number of clinical trial and lab studies across the globe. So I noticed today when I went on Dr. Grassley's university profile, this is presumably his own wording, that he says, Dr. Grassley is inevitably also working on the epidemiology of COVID-19, including testing and vaccination strategies. So in that role, he is a member of the WHO SAGE COVID-19 Vaccines Working Group and also a member of UK SAGE SPIAM. And I think today he's going to be talking to us about his work on modeling testing strategies for COVID-19 surveillance and control. So with that, I'll pass over to Dr. Grassley. Thanks again for joining us, and please do take it away.
Great. Thank you very much, James. And thank you everyone for joining. So what I decided would be maybe an interesting topic to talk about for this seminar series is looking at the impact of alternative testing strategies on the COVID-19 pandemic. And I think what's becoming very clear is that even with the rollout of vaccines, testing is going to be a key part of our response. In fact, possibly playing an even more significant role as we introduce vaccines. So I wanted to talk about the work we did earlier last year on a mathematical model of the impact of testing strategies specifically, and then hopefully open up for some discussion around how testing can be used to prevent SARS-CoV-2 transmission. So the context for this slide shows the number of daily COVID-19 tests per 1,000 people. This is from Our World in Data over time. And you can see that for many countries that the number of tests per person has really grown quite dramatically over the last year. And in fact, in the UK, we're really doing a lot of tests per person, with the US not far behind. But there's quite a variation between countries in the extent of testing going on. And I wanted to explore that a little bit in terms of how different countries are really taking quite different strategies with their testing resources. So back in March 2020, the WHO Director General called for countries to test. And at that time, there was quite a wide variation in testing capacity between countries. And there was a sort of observation that countries that seemed to be doing better in terms of their control of the pandemic, or control of their local epidemic at least, were those countries which had a greater testing capacity and were implementing their testing in a more widespread fashion. I think that picture is a bit more muddied now. It's not so clear that test numbers alone are the key driver of control of the pandemic. That pressure on testing led to daily targets. So, for example, in the UK, there was a very high-profile political commitment to do 100,000 tests daily by the end of April 2020. And then since that time, testing, as I've mentioned, has expanded, but with really evolving and quite diverse testing strategies over time. And then just in the last few weeks and months, a real increase in the use of rapid tests based on lateral flow devices, in addition to PCR testing, which formed the bulk of tests up to at least fairly recently for the majority of countries. Okay, so why is testing important in the control of COVID-19? Well, I think testing can play a number of different roles, and so we might want to do it differently depending on what those roles might be. So the first, of course, is routine surveillance and detection of outbreaks to inform our public health response to the pandemic. The second is more direct in terms of directly detecting and isolating infected people, and thereby directly reducing the reproduction number. Thirdly, negative tests can allow safe functioning of the economy and society. So this has been referred to as passporting. So having a negative test result to allow you to participate in events or to go to work, for example. And then finally, of course, testing is a key part of inpatient treatment in hospitals. And I won't really be talking about that at all. So I'm going to focus on the first three elements of testing. And what we did in our early work was to just use a very simple mathematical model of SARS-CoV-2 transmission to look at the impact of testing. And that model was based on describing infectiousness as a function of time since infection. And in this case, that's defined by the generation time distribution. So the average time between becoming infected and infecting others. So this is not based on viral load, it's based on what we observe from the epidemiology. And this I should have said, this is work that we released as a report from our MRC center in April last year, and then was published in Lancet Infectious Diseases in August. There's a GitHub page associated with where the code is provided. But the question of testing keeps coming up, and so we keep returning to this work, particularly through engagement with SPI-M and the UK SAGE. So in this model, the area under the curve is just the reproduction number, R. And so when an individual self-isolates following onset of symptoms, for example, or quarantines at a given time, then that will limit their subsequent contribution to transmission. And that's what we capture in our model. The time of self-isolation or quarantine will depend on the incubation period for symptomatic infections, so the time from being infected to showing symptoms, the availability of testing and how that might affect behavior, and in the case of contact tracing, the speed at which contact tracing is carried out. Okay, so just briefly, the model parameters. We assume a median generation time in the absence of self-isolation of around 6 days. And we look at a range around that median estimate. We use commonly shared assumptions about the incubation period distribution, the proportion of infections that are asymptomatic, around a third, the relative infectiousness of asymptomatic infections versus symptomatic infections, and then data on the sensitivity of SARS-CoV-2 tests over time since infection. And we use empirical data on that both for PCR and for the lateral flow devices. And so the data sources for those parameter estimates are shown on the right. And as I mentioned, we explore a range in sensitivity analyses as shown by the figures in brackets here on this slide. Okay, so looking at the just the effectiveness of self-isolation based on symptoms. This graph here shows that the effectiveness of that self-isolation in terms of the reduction in the reproduction number will be a function of both the proportion of infections that are asymptomatic and the relative infectiousness of those asymptomatic infections. So the more transmission that's associated with individuals who never become symptomatic and for increases in their contribution to the transmission, you can see, of course, the the relative impact of self-isolation on symptom onset is relatively smaller. For our central estimates of the model parameters, we expect a reduction in the reproduction number of around 47%, and I've given a 95% uncertainty interval there based on our parameter range. Of course, this reduction in also depends on the extent of pre-symptomatic transmission. So if we increase the median generation time from 6 days, which is what we currently assume, to 8 days, that it decreases the extent of pre-symptomatic transmission from 42%, which is broadly consistent with what we see from epidemiological data, to a lower value of 26%, then that would increase the reduction in the reproduction number to around 60%. So just a simple behavior in terms of self-isolating on onset of symptoms can have a substantial impact on the reproduction number. But of course, it's highly dependent on adherence to self-isolation and the ability to self-isolate and reduce infectiousness to others within the household. So in the UK, for example, adherence to self-isolation following symptom onset, at least over the summer, was reported at just about 20%. So the predictions in this model would simply scale linearly with the degree of adherence and the effectiveness of self-isolation. So we'd reduce the impact on the reproduction number by a fifth in this case. So it is very dependent on behavior and not just the biology of the disease. So where does testing come in here? Well, we can test individuals with COVID-19 symptoms to allow release of those individuals and potentially their quarantined households from self-isolation if they test negative. And so, so for PCR testing close to symptom onset, we know that the sensitivity of the test is high, around 90%. And so we would have a high negative predictive value. So for a prevalence amongst those tested of 5 to 10%, the negative predictive value would be around 99%. So we know that if we predict an individual to be negative, they should, in 99% of cases, they will indeed be negative, and we're not releasing infectious people back into society. And testing can, in these cases, also be linked to interventions to improve adherence. And that's something that's really been scaled up in the UK, at least over the last few months, in terms of providing income support, advice, and protective personal equipment. And testing individuals with COVID-19 symptoms is the basis of the NHS Test and Trace programme in the UK, which is a £22 billion investment, so a huge investment. And indeed, testing index cases is the basis of most contact tracing programs, I think, globally. So the idea here is that you would only, of course, follow up and try to identify the contacts of those individuals who test positive and have coronavirus or COVID-19 symptoms. And this has also been referred to as forward contact tracing, which is the focus of the UK NHS Test and Trace programme. So to capture that in a mathematical model, we just focused on the reduction in transmission from secondary infections generated by the index case. So those contacts where we hope to reduce transmission by essentially imposing quarantine. And the effectiveness of quarantine will be a function of when people are infected and the time it takes from symptom onset and testing and tracing to identifying the contacts and asking them to quarantine, shown on this graph as by the letter Q. So when we look at modeling this impact, in fact, for many index cases, we won't have an impact if they're either asymptomatic or they're symptomatic but not reached by the program. So in fact, the only impact on spread from those secondary infections is for those symptomatic indexed infections who are symptomatic index cases who are tested, who test positive, where their contact is traced, and in that case, it then depends on the delay to identifying that contact. What this means is that the impact of a test and trace program is very sensitive to its coverage. So the proportion of symptomatic individuals who are tested and the proportion of contacts who are traced. This extends to considerations of the use of, for example, cell phones to do test and trace, where the impact will depend both on ownership and use of a relevant app by the index case and by the contact. So the effectiveness of test and trace would always scale as a square of the coverage of that mobile phone and app or cell phone app in the population. And that's why we've seen relatively little impact of digital contact tracing to date, certainly in the UK at least. So what I've done here is plot the effectiveness of test and trace in terms of the reduction in transmission from the contacts as a function of the coverage of the test and trace program. In this case, I've just set the rate of testing and the rate of identification of contacts equal and plotted that on the x-axis against the time from testing an individual, an index case, to tracing their contacts. So from this graph, you can see that obviously a delay in identifying contacts decreases the impact of the program on transmission from the secondary cases. And that impact is really only felt once you start having a significant coverage. And it's really coverage that drives up the impact of a test and trace program. So if you're not if people aren't taking up the offer of a test, or they're not reporting their contacts, then we can expect the impact of the program to be limited. So at best, I think we would perhaps get a 25% reduction in transmission from contacts if coverage was 80%. If we could do testing and tracing and quarantining of contacts within 24 hours, and if quarantine was 100% effective in reducing secondary transmission. That reduction in spread from the contacts, we can apply the same algorithm to the contacts of the contacts and so on, and work out each generation. And if we make certain assumptions about coverage of the index case being independent of the probability of them being identified as a contact, then this reduction in transmission from the secondary cases does approximate the reduction in the overall reproduction number. And there's more details about that in the paper. So in reality, of course, the impact of the program is likely to be significantly lower. So in the UK, there's been a relatively low uptake of testing by symptomatic individuals, somewhere between 30 and 45%, depending on which time period we look at. Very few contacts are reported and are asked to quarantine. Only about 50 to 60% of index cases report contacts who are then successfully identified and asked to quarantine. And the mean number of contacts per index case is only 2, and many of those will be individuals living in the same household. It has taken a long time to get test results after onset of symptoms in the index case, and reaching out to the contacts and asking them to quarantine. Back in October, the mean time taken was 6 days. That has now reduced to 3 days in this last month, but that's still quite a long time. And of course, there's not only low adherence to self-isolation for individuals who have symptoms, there's even lower adherence to quarantine for contacts who are asked to quarantine without any additional testing offered to them, perhaps between 10 to 30% based on polling data. So if we put that together into the model, we get a reduction in the reproduction number of only around 5% if quarantine adherence is 100% effective. And if adherence is as reported, then that reduction is only about 1 or 2%. So we're not getting a big impact on the reproduction number from this big investment in forward contact tracing by the NHS in the UK at least. We can, of course, test contacts as well to allow them to be released from quarantine if they test negative. And that may also potentially increase adherence to quarantine if there is the prospect of being tested. I've shown here the reduction in transmission from contacts for a test, trace and test type approach, which would involve offering a PCR test to contacts and releasing those who are negative. In fact, what we see because of false negative tests, particularly early in infection, we see that the impact of a test, trace and test program is substantially less than a test and trace with immediate isolation program. And interestingly, if the impact is greater actually when there's a bit of a delay built into the system, and that's because we end up testing contacts when their infection is somewhat advanced and the sensitivity of the test is increased. So we're not testing during that pre-symptomatic period. That's with a single PCR test. There's a current discussion around the use of lateral flow devices with the offer of perhaps daily contact testing with a lateral flow device such that a single negative test would allow release from isolation or from quarantine. And that's something that's currently under consideration, at least in the UK, but not yet implemented. Okay, so how might we think about improving test and trace? Well, firstly, we need to improve we need to offer behavioral and economic interventions to promote test demand, reporting of contacts and adherence to quarantine, like financial aid. So I think that's really key. The behavioral aspect of this program shouldn't be overlooked. We can do recursive contact tracing where contacts who are tested and those that are positive, you also repeat the contact tracing for them. But of course, you get diminishing returns because by identifying those contacts, you hope that you're reducing their contribution to onwards transmission. Backwards contact tracing has the potential to be quite effective. So this is the idea of extending the window prior to symptoms about which you ask which contacts were made, because you're likely to have been infected by someone who has infected other people. In other words, you're selecting out those people who might be super spreaders by traveling backwards in your transmission tree. You have the potential to identify individuals responsible for a large number of secondary infections. The challenge is that this approach is very susceptible to delays in testing and in tracing backwards. And because we're increasing the window from typically would be from maybe 2 to 6 days about which we're asking during which we're asking about contacts, then we increase substantially the workload to the public health teams. And so I think for those reasons, this is not routinely done in the UK or indeed in many countries at all. Related, however, is the idea of doing a thorough case investigation and to ask about to ask about locations or activities where you have been in the preceding week prior to onset of symptoms, to try to identify those locations or activities associated with transmission. And that has been a little bit more effective, and I'll show you a little bit of data later that shows how that can be used to identify higher risk groups for transmission. Okay, so that's all on test and trace. I also wanted to talk about the use of testing as a regular screening program for people without COVID symptoms. And I know a number of you at CCDD have been looking at this and advocating for more extensive use of rapid tests to do regular screening. So of course, regular screening allows us to identify symptomatic infections before they become symptomatic, so in the pre-symptomatic period, shown on the left here, and also, of course, those individuals who would never have become symptomatic, or at least wouldn't have reported or noticed symptoms. And the effectiveness is going to be a function of the frequency with which that testing is carried out. And so on the next slide here, I'm showing the effectiveness of a regular screening program of those people without symptoms as a function of the screening interval shown on the x-axis here, and the time from the test to that individual getting a test result and isolating if they are positive. And so you can see again the reduction in the reproduction number is greater for faster testing, and it would be greater for more frequent screening as well. So for example, for a weekly PCR-based screening program where results are available within 24 hours and self-isolation following a positive test is 100% effective, this could reduce the reproduction number by around 23%, with some uncertainty around that. Additional reductions may be possible if you also implement contact tracing for these asymptomatic infections. And indeed, that is carried out in the UK. But as I showed on the previous slide, or previous slide, a couple of slides back, the impact of that forward contact tracing program at the moment is very limited. Again, effectiveness will scale linearly with adherence and the effectiveness of self-isolation, and also with the coverage of the screening program. In other words, what proportion of the population of interest you're able to reach with your regular screening program. At low coverage, the impact on the reproduction number is limited, but I still believe it may provide a useful surveillance tool. And I'll talk a bit more about that in a couple of slides' time. I did want to highlight what others have also shown, which is that using a less sensitive rapid test like a lateral flow device, although the impact is modestly reduced, it does offer some opportunities in terms of faster test turnaround and potentially, because of lower cost, more frequent testing. So on the left here, I've just shown the sensitivity of our mean estimate of the sensitivity of PCR over time since infection, and then superimposed on that in the open circles is the sort of an assumed sensitivity for a lateral flow device, which generally are positive during the peak period of infectiousness, which is from around 3 to 12 days. And this is sort of informed by the data emerging, particularly from the mass screening program that took place in Liverpool in the UK. So with a lateral flow device, if we were only to do that weekly and it still took us 24 hours as with PCR to get a result, then the impact on the reproduction number is significantly lower, just under 15% compared with PCR. But of course, a lateral flow device will give us immediate results. And so even with weekly testing with a lateral flow device, we would have a similar impact, at least for this set of parameters compared with PCR. And as mentioned, we may, with a lateral flow device, also be able to test much more frequently. In fact, with daily testing, we can really have quite a substantial impact on the reproduction number if adherence to self-isolation following a positive test is high, assumed 100% in this graph. I mentioned that screening, even with a lower coverage in a population, might be useful as a surveillance tool. So this just shows the probability of detecting an infection in a population where you're doing both symptomatic testing, but also regular asymptomatic weekly screening. And that's going to, the probability of detecting an infection will depend both on the probability of developing symptoms and then getting a test for the symptomatic component shown on the x-axis, and the coverage of the asymptomatic screening program. So if we imagine, we've certainly been considering this in the context of our university. If we imagine targeting university students, even if we have low uptake, we increase the probability of detecting an infection by 2- or 3-fold. And that allows us to detect clusters. It allows us to detect potential outbreaks in university halls and therefore to have a response. If we think about, for example, university staff who are more likely to be symptomatic and also more likely to request a test, then the relative benefit of an asymptomatic screening program may be less, and certainly at a low coverage level. So this gives a rationale for focusing testing as a surveillance tool, at least on students rather than staff in universities. And we can apply this kind of reasoning to other settings as well. So then the question arises, who should we target for regular asymptomatic screening? So when we first did this work, we were particularly interested in offering regular screening to healthcare and social care workers. We knew that COVID cases were disproportionately being reported among people in these occupations. And you can see from this seroprevalence survey here, conducted in England between April and July, that seroprevalence was significantly higher in those individuals working in patient-facing healthcare or resident-facing social care roles. And that continues to be the case, both looking at seroprevalence and infection surveys as well. There may be other occupations or occupational exposures associated with a higher risk of infection. And this is where backwards tracing or at least case investigation can help us identify higher risk groups. So this is just a subset of data published by Public Health England on the odds ratio of being a case as opposed to a control, with the cases identified through the NHS Test and Trace program and the controls interviewed through an online survey. And you can see that, for example, working in social and home care is a more high risk activity for being a COVID case. And that's true in August, September, and October. As we look down through the different occupations that I've shown here, you can see, for example, working in or attending education in August actually had a lower risk of being a case because, of course, we had the summer break. But in September, October, there was an increased risk of developing COVID if you were attending or working in education. So these data from the backwards tracing can be helpful in identifying populations where perhaps a regular asymptomatic screening program might be beneficial. So this is just a sort of theoretical plot showing how we might expect our impact on the reproduction number to scale with coverage in terms of number of tests for a targeted program versus a mass screening program. And I think it's been recognized both with the large pilot that took place in Liverpool and subsequent work that we can have a greater impact by being intelligent with who we target the asymptomatic screening program programs to. And just to highlight, this is a theoretical graph. This isn't based on real data on the left here. So we can prioritize by not only occupation, but we could also prioritize, for example, by age or by geography or socioeconomic group. And that, as I mentioned, can be informed by case investigation, testing data and seroprevalence data. We not only want to prioritize highly exposed individuals, but also those that might go on to transmit infection, and particularly those who might, where onwards transmission also has high consequence. So for example, those people who are in contact with vulnerable individuals with, for example, the elderly in care homes. The challenges with targeted screening are around the fact that these risks can be quite dynamic, depending on implementation of non-pharmaceutical interventions and stay-at-home orders, for example. There are key uncertainties, so in particular with the use of regular screening in schools, what is the impact of, what is the contribution of children to transmission of SARS-CoV-2? And then also unknown mixing patterns. If we want to extrapolate from the impact on an individual group to the impact on the reproduction number of the whole population, we need to know about mixing patterns, and those are really quite uncertain for some of the communities that we might be targeting. Okay, so I'm just going to end briefly by talking about passporting, which is really the idea of using testing to allow activities that would not occur without a negative test. This is something that is of course of interest to governments. Negative tests allow the economy and society to function. And I'm talking here beyond the release of those with COVID-19 symptoms and their contacts. The kind of uses might be to allow safe working, to allow events and mass gatherings, to allow team sport, travel, and school reopening and so forth. The key challenge, of course, with testing as a passport to allow activities to take place is that we do require a sensitive test to avoid false negative results that would result in an infectious individual participating in one of these activities that might be high risk to others. And then finally, the second part of passporting is something that I think has been gently dropped probably, and not really so much in people's minds, but was very much discussed early in the pandemic, which was the idea of having immunity passports based on either evidence of a past infection confirmed by PCR, or having an antibody test that's positive. So these so-called immunity passports could be targeted at specific groups, health and social care workers, for example, and allow their return to work and frontline roles, knowing that they have some immunity to infection. Of course, there are major challenges with their implementation, which is perhaps why they haven't been widely adopted. The first is around test performance. We really need very good positive predictive value. We want a positive test to really indicate that someone is truly immune, and to meet those requirements, we need good, very, very high sensitivity and specificity, particularly specificity. And you can see from this graph on the right, which was included in our publication back in last summer, many tests don't meet those requirements. Of course, immunity is only partially protective against infection, and we're learning more and more about the effectiveness of past infection in reducing risk of infection and subsequent transmission. And it is, of course, only partial. And then finally, there are ethical and behavioral economic reasons why offering immunity passports is problematic. Okay, so just to conclude, I think testing is essential for surveillance and can contribute directly to transmission prevention through isolation of infected people. Forwards contact tracing, such as the NHS Test and Trace program in the UK, really has a minimal impact on transmission, even with significant investment. And I think also the potential for improvement is actually quite limited. So case investigation or backwards contact tracing may, in fact, then have a more substantial impact. by identifying locations and behaviors associated with transmission. I think asymptomatic screening of high-risk groups can play a really important role, and it is indeed starting to play more and more of a role in reducing transmission when offered and taken up at high coverage, and also as part of surveillance and outbreak detection, even at low coverage. What I showed, and others have shown as well, is that asymptomatic screening with lateral flow devices is moderately less effective than PCR, but may have a bigger impact on the reproduction number because of the speed of results and the potential for more frequent testing as a result of their lower cost. And yeah, just to emphasize that massive scale up of testing with lateral flow devices is really now very much ongoing in the UK, and that's just now beginning over the next couple of weeks in the school setting to allow pupils to return to schools from the 8th of March. So with that, I'd just like to thank thank the Imperial College COVID-19 response team and my co-authors on the paper that describes this work. I'd like to thank members of the UK SPI-M and SAGE who have provided helpful comments and also lots of stimulating policy discussions, also as with Department of Health and Social Care. And finally, just to thank the Medical Research Council for centre funding. So thank you.
Thank you, Nick. That was really, really nice, elegant overview of so many different considerations when it comes to testing. I think it's very easy to think about testing as having this kind of one public health use, but I think that was a very nice overview. So just to remind everyone, if you want to submit your questions to Bene via the chat function, that'd be really helpful. We did say at the start, if you want to ask the question directly to engage in discussion, you're welcome to do so, but please do just ask the question anonymously as well if you would prefer. I'm happy to moderate the questions. So I'm going to take the privilege of moderator to ask you a first kind of very vague question, which is that, you presented some very clear and unequivocal modeling results. But what's really interesting is, so for example, I went to this BMJ webinar the other week on testing. And one of the kind of comments from some of the more, what I would say is kind of old guard clinicians of public health would be, oh, we shouldn't be kind of remaking the wheel at this point. We need to be focusing on contact tracing, and that's where we should be focusing our efforts. And I think it was so interesting to see just how ineffective your modeling results suggest that would be. I'm just wondering how, as in an advisory role, these conversations go and how that kind of feeds through to influencing policy.
Yeah, shall I answer, James, straight? Yeah. Yeah. So yeah, it's I think when we first did this work, the focus was still very much on we need to fix test and trace. So it's not working, but we need to fix it. And that's a huge investment of funds. I think over time it's increasingly clear that perhaps fixing it it's not about just increasing the speed, increasing the uptake. It's actually thinking about different ways of using testing, and perhaps forward contact tracing is not ever going to be the most effective use of our resources. And I think that's sort of fairly recently sort of been accepted by Department of Health more generally. And in fact, they have some of their own modeling efforts that were released a couple of weeks back, which also came to actually a very similar conclusion of a few percentage points impact on transmission. So then those discussions about how to use testing more intelligently are absolutely ongoing, and with UK SAGE and SPI-M and with the Department of Health as well. So and it's obviously I'm just one of the many scientific advisors and modelers sort of weighing in with our views, but that whole group is being marshaled very well by Graham Medley at SPI-M.
Very interesting, thank you. Because I'll ask a new question then. So this first question from the audience is, what do you think of the idea of people being asked to notify their recent contacts on their own as soon as they develop any relevant symptoms, that being in addition to the contact tracing that you discussed?
Yeah, I mean, I think that's a great idea, and should be encouraged. and when these surveys are done about, would you report contacts to test and trace, everyone says, oh yeah, absolutely, I would. But then for those people who do report contacts or who are eligible to report contacts, what's the actual behavior that happens? And it's actually a very small fraction who do that. I think, there are interesting behavioral reasons why someone might, if they test positive, they may not want to be telling, their workmates or social contacts that they've got COVID and that they should isolate as well. It's quite an awkward conversation to have.
So I had a follow-up question related to that. So do you think there's something more palatable to the public about, self-testing and gaining the information for yourself versus kind of being told by this kind of abstract body that you need to self-isolate because of something that you don't even know exists? In terms of, adherence to contact, self-isolation, contact tracing is so low. Is there any reason to think that adherence through receiving a positive lateral flow test will be any better?
Yeah, it's a good question. I think there's two parts. One is about the uptake of the lateral flow test, and willingness to accept that this is a real thing and that getting a test is helpful. I think having availability of those tests can encourage, or having more widespread availability of those tests can encourage uptake. So in the UK now, I mentioned this big increase in availability of lateral flow devices and rapid testing. And in fact, now it's possible, even if you don't have any symptoms of COVID, you can go and get a test. And what you do with those results, well, those results then get fed into the forward contact tracing program. The second part, I'm trying to remember, sorry, what was?
So I think it was about the kind of, it was about the adherence to kind of being told through a contact tracing network that you should self-isolate because somebody, maybe you never even met, you don't remember, was infected. Do you think adherence to that is going to be low, but adherence to something where you see the result in front of you, I'm positive, I should self-isolate? Do you think adherence might be better?
Yeah, no, that's a good question. So yeah, so this is really thinking about the contacts who currently might be contacted either through an app they've downloaded or they get a phone call and say, you're a contact of someone, we're not going to tell you who, but you need to, you're legally obliged to now self-isolate. And of course you can expect adherence is quite low to that. So that's why I think there's this consideration of offering daily testing for contacts with a lateral flow device. They would have to self-isolate until they get a test and that test is negative, and they would have to keep testing. The exact frequency I think is under discussion, but the hope is that, of course, testing to release is never going to increase the impact of the program unless it's associated with an increase in adherence in the first place to self-isolation. So the hope is by offering that test, it improves adherence. So I think that's that's why that's being considered, but I still do think it's still within this framework of willingness of people to report to seek a test in the first place if they're symptomatic and to report their contacts. And because those are still low, even with daily contact tracing, increasing adherence, I still think we're probably going to have a relatively limited impact, and we need to think about other ways of doing contact tracing, like the backwards tracing that I mentioned.
Great. So we have a question from Bill Hanage, who I think is happy to ask it himself. So Bill, if you turn on your camera, we can spotlight you, and if you unmute yourself as well. You should be able to. Can't be unmuted. Oh, there you go. Oh, I think
we can't hear you at the moment.
I think we're unmuting you at the same time as unmuting yourself. There we go.
You're unmuting me you're muting me while I'm unmuting myself. Yeah. All right. Hello there.
Bill, nice to see you.
Awesome. I wanted to just ask a really simple thing about the question of combining testing with other interventions. So for instance, there's a lot of kind of people will say, oh, if people get a negative test and it's a false negative, then they will go out and they will infect loads of people because they're going to go to a party or whatever. But it's always struck me as being a very simple thing to say that you use them in combination with something else. And so, for instance, I've always said that if you wanted to open a movie theater, you'd just say that people had to give evidence of a negative test, and then they'd wear a mask, and that would basically cut it down. So I was wondering if you had done any things in like combining interventions, or if you were thinking of doing it or anything like that. And again, thanks. That was a really good talk.
Thanks, Bill, and nice to see you. Yeah, I haven't done any modeling of you know, how that could be done. I mean, it falls under that slide on sort of negative test as a sort of passporting to allow activities to happen. So you know, so far that hasn't happened so much within the public sector, although you know, private organizations are offering, you know, regular testing to their workers, and I haven't seen it happening yet or allowed for events, but I agree, putting that together with other interventions like mask wearing that reduce risk could allow us to have you know, big parties like in the old days.
Thank you. So next question from, I think it's Callum Arnold, who has a question about pool testing that they'd like to ask themselves. So Callum, if you, I'm going to ask to unmute you. So if you should hopefully have had that request, you can ask the question.
Okay. Yeah, great talk. So thank you very much for that. My question was, early on in the pandemic, there was talk about pooling PCR tests as a way for increasing the frequency of testing a greater number of people. Was that something you looked at as part of your analysis and in the comparison against LFDs?
Yeah, thank you, Callum. So I didn't look at pooling, but there are plenty of publications out there on the value of pooling, and I think they all show that it can, you know, it can allow you to improve your number of tests offered. It can be challenging logistically to pool samples and to do the testing. Maybe I can give an example of doing that in our university, where pool testing seems to be feasible, but it's quite challenging to get a sort of cohort of 10 people, for example, to do swabs and then to combine those into a single tube to then allow subsequent testing. But in theory, and then of course, if you get a positive, then you don't know exactly who is infected, so you might want to go back and retest and so forth. But in theory, I think it's not a bad idea. It may be that with, you know, increasingly available and ever cheaper lateral flow devices, we might not need to do pooled testing, and so perhaps that's why it's less widespread than it might be otherwise.
Great. This next question is from Sheteng, but I'm going to ask it on her behalf. So I think a question generally about kind of use of PCR as opposed to other tests in the system in general. So the question is, how would you consider the long PCR turnaround time, usually more than 24 hours, and its impact on effectiveness, and also that how limited it is scaling up PCR? And I think the kind of second part of this question is more about this kind of long tail of RNA positivity, you know, that kind of, you know, succeeds the infectiousness period. So just a comment on that, I suppose.
Yeah, I mean, yeah. So I mean, yeah, PCR can take time, although I mean it can be optimized, and you know it can be pretty quick actually. You know, certainly within 24 hours. So it can be quite quick. It's more expensive than a lateral flow device, and it needs more infrastructure. So I think, and as I showed on some of those analyses, you know, the delays that in practice with PCR have had a detrimental impact on the effectiveness of testing strategies. And yeah, you're right that you know, detecting people late in infection who are PCR positive but perhaps not infectious. I see there's a comment from Michael Mina. I know he and others have published quite a bit on this, and of course, identifying those individuals might not be so valuable for then trying to do forward contact tracing, or for an impact through their own self-isolation. It might be more useful actually, though, if you're doing backwards tracing, because you might be able to detect the person who infected your index case because they're still shedding by PCR, whereas they might not be by a lateral flow device.
I think it's always, every time I tell any of my American colleagues that I've been tested through the NHS and it takes less than 24 to 40 hours to get a result, they're astounded. So I think it's, 24 hours seems very doable in the UK, but throughout most of the US, it's really been a pipe dream. So I think we've got sort of 2 minutes, and I see Michael Minna wanted to ask a question about contact tracing. So Michael, if you turn your video on and we can unmute you and all that.
And a wonderful talk. I guess that, so much of the talk was about contact tracing, and this idea of using contact tracing as a way to combat this virus, I think, has obviously, and for obvious reasons, been kicking around since the beginning. But when we go back to January or February of this pandemic, we all, whoever all is, but we said contact tracing would not get us out of this once cases started to essentially increase. But then we have continued to just kind of forget that we said that early on. And what I've noticed is that, we have put immense resources into contact tracing. We have sort of, in some ways we've prevented certain tests like these to come out because of, initially it was because of low specificity and all different things and low sensitivity. In some ways, in the midst of a major pandemic, contact tracing and quarantining individuals with exposure is sort of a very non-specific test, if you will. And I guess I just wonder, in the context of what we've seen transpire, in your view, do you see that there is a, what am I trying to ask? When we look at all the logistics associated with it, when cases are raging out of control, is it even worthwhile trying to really go down this road of contact tracing versus either just mass lockdown or versus try to get these in every house, like when we haven't really seen it being effective as a strategy?
Yeah, thanks, Michael. Yeah, I mean, I've got a view on this, which, yeah, I from doing this analysis and more that are emerging, it's clear that the contact tracing component of test and trace in the UK, at least, is having a minimal impact. Of that £22 billion that I quoted, 80% is the testing of the index case, and then the 20% is sort of the contact tracing bit plus some logistics and stuff. So it's still a lot of money, but it's not, the bulk of the money is not the contact tracing, although it's still a huge amount of money. The argument for doing the testing, the 80% that's spent on testing, is that if you have a negative test and you're symptomatic, then you can release from self-isolation. I think that there's slightly it's a little bit unclear quite what that benefit is, though, because if people are symptomatic, they're usually ill, so they're probably going to stay at home anyway. And by the time they get a test result, they're probably quite far down the kind of self-isolation route. So the actual impact of even that part of the budget is perhaps rather small. So I mean, I totally agree with you. I think looking at other ways of using testing both for identifying where transmission is happening, and then using regular screening to prevent transmission is a better way of using our testing resources. But it does need a huge scale up in investment in those tests. Yeah.
Great. Well, we're just past the hour, so I think it's probably a good time to wrap up. So let's thank Dr. Grassley again for a fantastic talk and great discussion. And just to the closing kind of statement. So just to say, on behalf of the Center for Communicable Disease Dynamics and the Harvard School of Public Health, thank you everyone for coming. Thank you, Dr. Grassley, for a great talk. Just to remind everyone, if you have any further questions about the seminar series in general or for Dr. Grassley, please do email one of the seminar organizers, and we can pass your question on to Dr. Grassley. And we'll be continuing to post updates of future talks on the CCDD website. So thank you everyone again for joining. Thank you, Nick, and yeah, everyone have a good afternoon.
Thank you.
Bye.
Bye-bye.